Good evening all and welcome to this another YouTube live session. Continued from yesterday, head neck part 2 continued. High-level MCQs head neck part 2, myself Dr Ankit Khandelwal, MBBS MS Anatomy, your educator of anatomy in Unacademy platform. Let's start the session. Let's proceed from here. Few things that we can see about the Unacademy. Latest things are over here. April, free tests. Unacademy light feature, Prof 1 new batches have started. Auto daily practice papers after every plus class. You can use the code Dr Ankit live to enroll for any of the courses or get a 10% discount. Doubt clarification batch, special class features, educator revision batch series, and year 1 foundation batch is also there. Plus few offers going on. You can avail the benefits of this. And yeah, the 3 subscriptions you can choose, and you can for 10% discount. I already told you the code Dr Ankit live that you can use. So let's start the session. Let's start some of the MCQs over here. Good evening all of you. I hope you all are doing fine. Let's continue the session. Here is the first question, and it says that a 47-year-old man complains of right arm weakness and difficulty speaking. That is sort of expressive aphasia. Okay, right arm weakness and difficulty in speaking. Which of the following arteries is most likely affected? Okay, is it a vertebral artery? Is it a posterior cerebral artery? Is it a middle or an anterior cerebral artery? So there is a expressive aphasia, 2 positive points from here, and there is a weakness of right arm. Weakness of right arm. What do you think? You can have a comment box. You can write ABCD as the option, whichever you think is the correct answer over here. And yes, we will see over here. But yeah, what do you think? Started with option number C, middle cerebral. So there is a right arm weakness and difficulty speaking. Now, right arm weakness could be due to many things, but they're saying yes, expressive aphasia. Aphasia over here, expressive is for the Broca's area. We know Brodmann's number 44-45, dominant hemisphere. Which right or left hemisphere? Normally it is the left hemisphere which is dominant over here. So if the left hemisphere Broca's area is damaged, fine. Why would there be a right arm weakness? Because the corticospinal fibers, they cross at the lower part of medulla oblongata. So yes, it is justifying. The second point comes that this Broca's area and the motor area for the upper limb is supplied by which artery in the brain? Which artery in the brain? So if you look over here at the left cerebral hemisphere over here, there is the central sulcus, right? There is the precentral gyrus and the postcentral gyrus. Over here we have the Broca's area. The artery which is supplying this zone, because involvement of Broca's as well as the motor area, precentral gyrus is a motor area. Which artery over here? The artery which is coming from the lateral sulcus and distributing the branches is the middle cerebral artery. Yes, very good. It is the middle cerebral artery as all of you. So the answer is middle cerebral artery. Okay, now understand over here, though in brackets they have written expressive aphasia. In the bracket they have written expressive aphasia, so it gives a big hint. But there are other situations also that we'll see in the other questions. Moving to the next question. A 2-year-old girl is diagnosed with torticollis involving the right SCM is sternocleidomastoid. Right SCM, torticollis. Which of the following describes the most likely anatomical change in that 2-year-old girl? Torticollis, right SCM. Options are head flexed forward in the midline, head rotated to the right like this, head rotated to the left like this, or head extended in the midline plane. Extension, flexion, rotated towards the right, rotated towards the left. Problem is in the right side SCM, torticollis. What do you think is the correct answer over here? Let us see. You're waiting for your options. C's and B's are coming till now. Right side torticollis. SCM. Imagine the muscle attachments, mastoid going down towards the sternum and clavicle. This is the muscle. Torticollis is fibrosis and contraction, or you can say yes, fibrosis. So contracture, not exactly contraction, but contracture of the muscle. So muscle is shortened. When this muscle is shortened, imagine where would the head move? Will it rotate towards the right side or will it rotate towards the left side? Now keep on imagining this. Imagine the V over here, and this limb of the V is now shortened. So when this is shortened, the head would rotate to which side, and that would be the answer. The head is rotated towards. Excellent, very good. Most of you Head is rotated towards the left side. Obviously not flexion, not extension, but rotate towards the left side, right side torticollis. Point clear? I hope that is clear. SCM is supplied by which nerve? What is the nerve supply of this muscle? Spinal accessory nerve. Spinal accessory nerve. It supplies this as well as the trapezius. Right? Moving to the next question. Yeah. No, it's C, Dr. Priya. It's not B, it's C. Let's see this question. Okay. 45-year-old female is admitted to the hospital with severe headache, dizziness and vomiting. Patient presenting to you with a headache, with a dizziness and vomiting. Looks like a neuro thing. Radio examination reveals an intracranial tumor. Upon physical examination, the patient has now findings, positive findings. Dryness of the nasal and paranasal sinuses. Dryness. Nose is dry, paranasal sinuses are dry, fine. Loss of lacrimation. Dryness. And loss of taste from the anterior 2/3 of the tongue. Anterior 2/3, taste is also gone. Which of the following structures most likely involved with the tumor? Three things are there. Nose is dry, eyes are dry, and taste is lost from the anterior 2/3, right? These are three positive findings that we can take out from the question. Is it a involvement of the lesser petrosal nerve, facial nerve, inferior salivary nucleus, or pterygopalatine ganglion? Mark your answer, guys. Think what should be the best answer. I've written over here separately the three positive findings. Dry nose, dry eyes, lacrimal gland, lacrimation, so dry eyes, and taste loss from the anterior 2/3. What do you think is the correct answer? Lesser petrosal, facial, inferior salivary nucleus, or pterygopalatine ganglion? Okay, meanwhile you guys are thinking. Petrosal nerves are quite confusing. Okay, so we will spare one more minute to this petrosal nerves and we'll discuss them, don't worry. But now let's come to the question. Nose and paranasal sinuses are dry. What is supplying these mucosa and serous glands? The nerve is a post-ganglionic nerve. From which ganglion? Pterygopalatine ganglion. Fine. Lacrimal glands coming from pterygopalatine ganglion. Fine. Taste from anterior 2/3 which nerve? Cauda tympani nerve. Fine. But sir, PPG is an option, CT is not an option, so what to choose? What is the preganglionic to the pterygopalatine ganglion, which is the preganglionic nerve? Greater petrosal nerve. Very good. So problem could be in the greater petrosal nerve for these two findings. Problem could be in the ganglion. Problem could be in the postganglionic nerve. Normally it is the branch of maxillary nerve over here, and V1 also. But yeah, problem could be anywhere. But if you look over here, the cauda tympani, greater petrosal and cauda tympani have what in common? What do they have in common? They are coming from a common nerve. Which nerve is that? That is the facial nerve. Fine. So if we choose facial nerve, we can explain all these three findings, and therefore actually facial nerve is the answer. But the second confusing option was this pterygopalatine. But you can't explain the loss of taste from the anterior 2/3 of the tongue by the pterygopalatine ganglion. Remember that. Fine. Answer is facial nerve. Now coming to this petrosals. Petrosals, now why do we give their names as petrosal? Because there is a petrous part of temporal bone and the nerves are related to it. The nerves are related to it, so we call it as a petrosal nerves. Second, the venous sinuses which are related to the petrosal part of the temporal bone are known as superior and inferior petrosal sinuses. So it is anatomically the petrous part of temporal bone, we call it. How many petrosal nerves are there? Two we already have seen, the greater petrosal nerve. Greater. Fair enough. One was the option as the lesser petrosal nerve. Very good. And this third petrosal nerve, this third also known as the deep petrosal nerve. Deep petrosal nerve. Remove the confusion today itself. The greater petrosal nerve is actually a branch of 7th. It goes to the pterygopalatine ganglion and it does its job over there. The lesser petrosal nerve is a branch of 9th nerve, glossopharyngeal. It goes to which ganglion? The otic ganglion. And what does it supply? Otic, parotid gland. What about this deep petrosal nerve? It is lying deeper inside the petrous part of the bone. Tell me which organ is inside the petrous part of temporal bone? Which organ is inside? Ear. Ears are inside, right? So close to it we have this. And close to the middle ear, just anterior to the middle ear, anterior inferiorly, we have the artery known as internal carotid artery. So deep petrosal nerve is nothing but a sympathetic nerves around that internal carotid artery, because that is close to the petrous part of temporal nerve. So this deep petrosal nerve is sympathetic. These two are branch of 7th and 9th. I hope the confusion should now be no more. Okay. So coming to the question, answer was facial nerve and little bit of explanations of this. Now there is one more option over here, inferior salivatory nucleus. Inferior salivatory nucleus is related to 7th or 9th nerve. Who will answer this? Salivatory. Salivation, parotid, submandibular, sublingual, and nowadays one more tubarial gland. But this inferior salivatory nucleus is related to 7th nerve or 9th nerve. That is the point over here. What do you suggest, guys? Inferior salivatory nucleus. Parotid gland is over here, related to the 9th nerve. Submandibular, sublingual are related to the 7th nerve. Chorda tympani and lesser petrosal. So inferior salivatory nucleus is related to the 7th nerve or 9th nerve. What do you think? Ayushi says 9th. Perfect. It is 9th nerve. Because when we say nucleus related to the brain, in brain stem the 7th nerve is superior in comparison to 9th nerve, which is inferior. How come, sir? Because in the brain stem we have this midbrain, a big pons, and a narrow and a long medulla. 7th nerve nucleuses are over here, the 9th nerve nucleuses are over here in the medulla, and that is in the pons. So in the nucleuses, this is the inferior salivatory nucleus for the 9th nerve. This will be the superior salivatory nucleus for the 7th nerve, along with one more nucleus, lacrimeatory nucleus. Clear? I hope the confusions are clear now. Let us move to the next question. Here we have 45-year-old lady is admitted again to the hospital, but the different lady, for a severe ear pain. Okay, earache. Physical examination reveals chronic infection of the mastoid ear cells. Fine. The infection can erode the thin layer of bone between the mastoid ear cells and the posterior cranial fossa, and spread most into which of the following venous structures? Anatomically, what venous structure is between the mastoid and the posterior cranial fossa? Which venous sinus is over here? That they are asking. Is it superior sagittal, inferior sagittal, straight, or sigmoid? Answer: A, B, C, D. A, B, C, D. Think. Keep on thinking. Take your time. Take a little bit of your time. Yeah. Options are coming as B's and D's. D's and B's. What is D? Sigmoid sinus. What is B? Inferior sagittal sinus. Okay. Which one is the correct? Correct is the sigmoid sinus. How come? Why not B? Sagittal. They are saying sagittal. It means they are in the midline. They are in the midline. And mastoid are paired. One is over here, one is over here. So you can easily, by common sense, rule out these two options. Same for the straight sinus. It is unpaired in the midline. So actually, by simple exclusion, you reach a diagnosis of, okay, it could be sigmoid sinus. Now I have a skull over here to show to you. This is the norma frontalis, that is on the lateral part. This, I guess, you can easily see the mastoid process, right? And if you look inside, this is the anterior, middle, and posterior cranial fossa. This is the posterior cranial fossa, this is the mastoid process. Now if you look closely, if I put my finger over here, this finger is projecting towards the groove for the sigmoid sinus. That is exactly medial to the mastoid process, and this is the posterior cranial fossa. This is sigmoid sinus groove. This is the petrous temporal, and lateral to this we have the mastoid, which is right over here. Mastoid, and just inside this sigmoid sinus. This is how the sigmoid sinus thrombosis could be a complication of the mastoiditis or in later stage of CSOM. Answer is sigmoid sinus. I hope the point is clear. How you can easily rule out these, and how you can easily reach the answer. Even if you don't know all of this anatomy for, let's assume, but still common sense prevails, right? Let's see the next question. 56-year-old man is diagnosed with an extradural tumor outside the dura in the posterior cranial fossa. You have just seen the posterior cranial fossa, fine. When the patient protruded his tongue during physical examination, the tongue deviated to the right. Tongue went to the right side. Protrusion and going to the right side, fine. Which of the following muscles is most likely injured? Right side genioglossus, left side genioglossus, right side hyoglossus, or left side styloglossus. All these four are glossus, all these four are tongue muscles. So which tongue muscle is involved over here? Ayushi is going with the, okay, right genioglossus, others are going also right. So this is a normal tongue, that is the right side, this is the left side. Ask this patient to protrude the tongue went to the right side, right and left side. Which muscle is commonly involved? Most of you are going with A option, fine. Understand over here. Let me take an empty page over here. So this is the normal tongue, right? This is the action of right genioglossus, that is the left genioglossus, if this is right and left side. They push the tongue forward and medially like this, and when both genioglossus are normal, the tongue is protruded straight in front like this. Now, the tongue, if it shifts to one side, suppose in this it's shifting to the right side, right? Shifting to the right side, it means that the right genioglossus over here is not working, the left is pushing it forwards and medially. So tongue protrudes to the right side. The problem is not with the left, but it is with the, as most of you correctly answered. Very good, right? No, it is not left, it is right genioglossus muscle. Hyo and stylo, what do they do? Hyoglossus, imagine the tongue over here, and just imagine if this is the tongue, where is the hyoid bone related, suppose sagittal view, where is the hyoid bone related to the tongue? Is it above, below, anterior, posterior? It is slightly posterior over here. Assume this is the hyoid bone. So hyoglossus will be pulling the tongue in this direction, backwards and below. The styloid process is over here, and styloglossus goes like this. Styloglossus will be pulling the tongue behind and upward. Okay, so understand them. Palatoglossus is over here, right? And genioglossus is right over here. So when it contracts, it pushes the tongue forward. Okay, in this question, answer is option A. I hope it is clear. No, yes, the answer is right genioglossus, not the left one. That was the main confusion, but just telling you this. All of these are supplied by the 12th nerve, because here we don't have any palatoglossus. Next question, an image-based question. 54-year-old lady comes to the physician because of a one-day history, just a one-day history, fever, chills and double vision. Suppose you are sitting in an OPD, just one day history of fever, chills, you may think of any cause like UTI or malaria, this and that, whatever, but and double vision. Now she says, I am seeing two doctors. In place of one, I am seeing two doctors. Okay, fine. She also has a 2-week history of headaches. Then she will say that from 2 weeks I have been having headache and foul smelling nasal discharge. Don't directly away think of mucormycosis or rhino or something because of this COVID, but yeah, she had a 2-week history of headache and foul smelling nasal discharge. Her temperature is 39.4, corneal reflex is absent. Absence of the corneal reflex is most likely caused by compression of which of the following labeled structures. So the question boils down to this. Initially it's looking like a clinical question of medicine. Suddenly it boils down to this, that in this image, and this image, let me give you a hint, this is a cavernous sinus, it's a coronal section of cavernous sinus. So in this image they are saying that compression of which label A, B, C, D would lead to absence of corneal reflex. And what is your answer over here? What is your answer over here? Okay, D's and V1s. Alright, look at the coronal section. This is the sphenoidal air sinuses. This is your pituitary gland, right? This is the right and left cavernous sinus. This artery is the internal carotid artery. But what are these nerves? In the lateral wall, we have third nerve, fourth nerve, V1, and V2 is plus or minus, may or may not be present. V2, remember, maxillary division. This one over here, option number A, is sixth nerve. Corneal reflex, I guess we discussed day before yesterday. If you just touch the corneal conjunctiva with the wisp of cotton, suddenly there's closure of the eyes. Afferent is by the V1 and efferent is by the 7th. So afferent is by the V1, efferent is by the 7th. 7th nerve nowhere, but yeah, V1 is present. V1 is over here. Answer is, I guess most of you did mark it. Very good. Very good. Option D. Option D. So they can ask you many questions like she's having double vision. Okay, eye is not able to adduct, or there is a medial squint. Then you have to think for sixth nerve. Eyes are looking down and out. The pupils are dilated. Think of third nerve, and so on and so forth. So questions can be just understand which nerve does which function. You can choose out, right? Moving to the next question. Here it is. 31-year-old female is admitted to the hospital after an automobile collision. CT reveals a large hematoma inferior to the right jugular foramen. So there is a hematoma just below the right jugular foramen. Physical examination reveals right pupillary constriction, meiosis. So right side there is meiosis and anhydrosis of the face. So there is meiosis as well as anhydrosis. That is, I hope you know what is anhydrosis, loss of sweating. Which of the following ganglia is most likely affected by the hematoma? So there is a hematoma below the jugular foramen and there is meiosis as well as anhydrosis. Which ganglia is affected? Is it submandibular, trigeminal, superior cervical or ciliary? Let us see your options. Let us see your comments. Correct answers. What do you say? These two features are there. Pupil, normal size pupil, now it has become smaller size. There was a lot of sweating present, sweating absent. What do you think? Which function is getting lost? Think about it. Which function is getting lost? Pupil has two sort of muscles, sphincter pupillae and dilator. Dilator will dilate, sphincter will cause meiosis. Okay. If the pupils are getting contracted, it means that dilator pupil is not functioning. So there can be a non-action of dilator pupillae. Agreed? They can be. Sweat glands which nerve supply them are the sympathetic nerves. Fine. Dilator pupillae, who supplies dilator pupillae? Again sympathetic. So it appears like there can be some loss of sympathetics, like simply Horner syndrome, if you can understand that part. Out of these four, which is a sympathetically related option? Submandibular is a parasympathetic ganglion. Trigeminal is a sensory ganglion. Superior cervical, this one is sympathetic. This should be the answer. Ciliary again is parasympathetic. So two are parasympathetics, one is sensory, but this the answer. This is the superior cervical, related to the Horner syndromes. Remember, there are two sort of Horner syndrome, a central and a peripheral. That whole flowchart over there. So superior cervical ganglia is related to it. Plus, it is close to the jugular foramen, below the jugular foramen, right? So that would be our answer over here. Point clear? Even if you don't know the details of this, just figure out what is missing in this patient, which function is missing in this patient. Think logically. You will somehow come to the point of sympathetics looks like missing. Then think about this, which ganglion is sympathetic. Remember cervical, superior, middle, inferior cervical. These three are sympathetic, three cervical sympathetic ganglia. Inferior cervical merges with the first thoracic ganglia, right? Striate ganglia, cervical thoracic ganglia. So I can approach the question this way also. I hope point is clear. Moving to the next one. Arterial circle. Arterial circle contributes greatly to the cerebral arterial circulation, the Willis circle of Willis. When one primary artery becomes occluded by the atherosclerotic disease, see, that is a function of the circle of Willis, that when one artery gets occluded, the other might help. Which of the following vessels does not contribute to the circle? I hope the question is not that difficult. A, B, C, D, anti-communicating, post-communicating, middle or the internal cerebral, internal carotid artery, middle cerebral and internal carotid artery. C's and C's and C's. We can see a lot of C's. Very good, very good. Yes, answer is definitely middle cerebral artery. Though it is the main continuation of internal carotid, but not contributing directly to the limbs of the so-called circle of Willis. Why I am using circle of Willis? Because it is never a circle. We call it a circle of Willis, but it is never a circle. It may be trapezoid or hexagon or pentagon in shape, depending on which vessel is how much long, but it is never a circle. So-called circle of Willis. Now let us see over here. The two internal carotid arteries from below, if you look from below, their branches the two anterior cerebral arteries. Which arteries? Anterior cerebral arteries. They are sometimes joined by a very small anterior communicating artery. Then it gives a very small posterior communicating artery, PCOM, posterior communicating artery. That is ACOM, anti-communicating. And from below there is a basilar artery which is coming by the union of the two vertebral arteries. And this basilar artery gives off the two posterior cerebral arteries, So what vessels contribute to the circle of so-called circle of Willis are the anteriors and posteriors, cerebral and communicating. Same over here, cerebral and communicating. Anterior cerebral, anti-communicating, posterior cerebral, posterior communicating, plus a little bit of ICA, if you can say over here. Where is MCA? MCA goes laterally out from here, running inside the lateral sulcus. It goes laterally out. Out where, sir? We have seen in the brain part, it is coming through the lateral sulcus. So in the midline, it goes laterally out, then it comes out from here, it supplies all of that. Remember that first question of Broca's, first or second question? Broca's area, Broca's aphasia, as well as right arm weakness, middle cerebral artery. So therefore the answer over here is middle cerebral artery. This much explanation is fine. Let's move to the next one. 54-year-old male is diagnosed with an aneurysm of the basilar artery close to the cavernous sinus. An anterior approach to the sella turcica through the nasal cavity is performed. Now think like a neurosurgeon. Through which of the following routes is the surgeon, that is a neurosurgeon, probably most likely to enter the cranial cavity? I repeat again the question. The problem is in the basilar artery. There is some aneurysms. The surgeon has an anterior approach to reach the sella turcica through the nasal cavity. Through which route will the surgeon reach the cranial cavity? Via nose, cribriform plate, cavernous sinus, frontal or sphenoidal sinus. The question is not that difficult, but this is a venous sinus over here, this is the air sinus. Remember, frontal is also an air sinus. These are two air-filled cavities. This is a blood cavity. This is a cribriform plate, is a part of the bone. What is the answer over here? D is mostly going to D. What is D? Very, very good. Sphenoidal sinuses. Sphenoidal sinus. I will try to show you over here if you can possibly see this. See, this is the skull over here, right? I hope you can see, guys. This is sella turcica. The pituitary gland is over here. The pituitary gland is over here, and this is a part of the brain stem. The basilar artery comes over here, and then it goes into the two posterior cerebral arteries. Remember, the IC is coming from here. Posterior communicating arteries over here, right? Basilar artery aneurysms is there. Now nasal cavity is over here. If you remember the anatomy of the nasal cavity, the opening of the nasal sinuses, then there were, remember the superior meatus, the middle and the inferior meatus, and at the top you had a sphenoethmoid recess, if you remember. And which air sinus opened into it? This air sinus, sphenoid sinus, air sinus. This opened into normally sphenoethmoid recess. That is whole nose. This hole is nose. You're entering through the nose. You reach this sphenoid sinus. You just go through it. You are reaching over here, and here is the basilar artery. So that is the answer. Is simple anatomically. This is known as transsphenoidal approach, intranasal transsphenoidal approach to reach the pituitary gland and the area structure around it. So answer is our sphenoid air sinus. I hope the point is clear. Let's see the next one. 54-year-old man was admitted to the emergency after he was struck by an automobile. Radio examination revealed a fracture through the crista galli of the anterior cranial fossa. It's part of the bone, thick bone, resulting in slow local bleeding. Slow local bleeding. Which structure is most likely the source of this bleeding? Middle meningeal artery, the great cerebral vein of Galen, superior sagittal sinus, or the superior ophthalmic vein? What do you think is the answer over here? Think. Keep on thinking. What do you think is the answer over here? The crista galli of the anterior cranial fossa. Slow local bleeding. Two big hints over here. What do you think is the answer? Okay, we have the options coming. D's and D's and D's. Very good. So, first of all, remove the artery because it is a slow local bleeding. Where is, sir, this crista galli? This is again, we are coming, this is the anterior cranial fossa. This projection over here is the crista galli. Sorry, over here. This is cribriform plate, this is the crista galli. These are the frontal sinuses. This is crista galli. Which dural fold is attached? Fox cerebri. And which venous sinuses are over here? That is the answer which you guys have chose. You guys have chosen C or D. You are going, oh no, not D. It is C. Okay. It is superior sagittal sinus. Sir, why not superior ophthalmic vein? Why not superior ophthalmic vein? This is crista. Where is superior ophthalmic vein? Where is superior ophthalmic vein? Is it inside the skull or is it inside the orbit? Where is superior ophthalmic vein? Superior ophthalmic vein, if you remember, contents of what? The fissure over here. The orbital fissures over here. It is the content of the orbital fissure. Superior and inferior ophthalmic veins. And where do they drain? They drain into the cavernous sinus. And look at my finger over here. The tip of my finger is showing towards the cavernous sinuses. And right in front of it, you have the superior orbital fissure. Can you see the superior orbital fissure over here? Superior ophthalmic vein is coming from here, inside the orbit, draining, coming via this, going into the cavernous sinus. Crista galli is over here. Ophthalmic vein is over here. Got the point? It is not directly related to it. Answer is our option number C, superior sagittal sinus. Remember, it is an attachment, crystallia is an attachment of the fossa cerebri, and which venous sinus is related to the fossa cerebri? This. Galen is present posteriorly. Artery you can rule out. Ophthalmic I already showed you where it is present. Point clear? I hope it is clear. Let's move on. Let's see what else we have in store. A 27-year-old man is admitted again to the hospital after a middleweight boxing match. During physical examination, the strength and symmetry of the strength in opening the jaws are tested. Boxing, fine, you test this as a doctor. Which muscle is the most important in two things? Jaw protrusion and depressing the mandible. This is actually the question. Last line is the question. Which muscle is most important in jaw protrusion, not retraction, protrusion, and depressing the mandible? Okay. Options are anterior portion of temporalis, lateral pterygoid, middle pterygoid, or the mylohyoid. Think. B's and okay. Most of you going with B's and B's. Very good. And Nimesh is fond of typing, so wrote the whole answer lateral pterygoid. B is lateral pterygoid, right? Okay, fair enough. Good one. Yeah, answer is this. But think, if this is not the option, what is the second best answer? Suppose this is not the option. What is the second best? What is closest to this? The muscle which involves in depressing the mandible is lateral pterygoid and mylohyoid. Both. They both will depress the mandible. In fact, let me tell you, mylohyoid has a bigger role in depressing the mandible than lateral pterygoid. Yes. Please read all the time. Now, lateral pterygoid, opening of mouth, fine. But it only assists in opening of mouth. Mylohyoid is over here. Mylomandible hyoid is this. This whole muscle, when it contracts, opening of mouth, it will assist. But jaw protrusion is only done by lateral pterygoid. Why? Because it is going from anterior to posterior. Lateral. So when it contracts, jaw is protruded front. Mylohyoid will not cause jaw protrusion. Getting a point? I repeat again, depression of mandible is a feature of these two muscles, but protrusion of jaw is only of this. Temporalis, middle pterygoid or masseter, they all will close the jaw. Remember this? Fine? Let's see. And what is the nerve supply of, let me ask you, which muscle? Mylohyoid. Answer me. Which cranial nerve supplies mylohyoid muscle? Think and answer. Which cranial nerve? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, all the options are there. Mylohyoid muscle. Nerve to mylohyoid is a branch of, I'm waiting for the answer. Let us see if you write this in the comment box. Yes, fifth, B3, mandibular division of the trigeminal nerve. Fine, let's move to the next one. Okay, here we have a question on asking a patient to say this sound like ENT clinic, OPDs, you just ask the patient to open the mouth and say so they can look what is happening in the posterior pharyngeal wall. So asking a patient to say the uvula is seen to be drawn upward to the right side. Uvula normally, you see uvula like this, and when you see this patient, the uvula is drawn upward to the right side. So uvula is drawn somewhat like, if I may make it like this, upward to the right side. Which nerve is damaged? Simple question, straightforward. Which nerve is damaged? Left glossopharyngeal, right hypoglossal, left cranial accessory nerve, or right vagus? Which nerve is damaged? Think about it. It's not a very simple question, but not a difficult one too. But give it some time, 10-15 seconds, try to think about the answer. Uvula is going to the right side. Someone is pulling the uvula to the right side. Uvula is a part of soft palate, the musculus uvulae, the tensor palatii, levator palatii, palatopharyngeus, palatoglossus, all these muscles are part of soft palate. The right side uvula is being pulled. This is right, that is left. Which side uvula is, muscles of uvula are not active? Right or left side? Let me see your options now. A's and C's. What is A? Left glossopharyngeal. What is C? Left cranial accessory. Someone has written A also with a question mark. Question I am asking, you have to give the answer. Why putting question mark? Question mark is my job over here. This is the question mark. You don't have to put a question mark. You have to give the answer. It is like in Viva, na? So what is the answer? Then in Viva you answer like, sir, left vagus. So it is giving answer and also asking the doubt. So Don't play games over here. It is not a viva. What is the answer over here? See, the left side soft palate muscles are not working. Which cranial nerve supplies the soft palate? It is a pharyngeal plexus. Mainly it is also we call it as a vago-accessory complex. So it is left vagus or left accessory nerve. Which cranial accessory nerve? Answer is option number C. Why not A, sir? Glossopharyngeal, we have discussed a lot of time. It is sensory. Here it is a movement, it is a motor part which is getting lost. There is no word about the sensory loss. There is nothing about the sensory loss. Glossopharyngeal is sensory. They are saying uvula is drawn upward to the right. It is a motor thing in the uvula. They are not saying that the patient is not able to sense anything, the gag reflex is lost, or patient is aspirating the food and fluid items. So it is not a sensory problem, it is a motor problem. Think motor. So motor, there are two options, vagus and cranial accessory. But vagus right side, right vagus is fine there. That is why it is being pulled to the right side. But left side is problem. Left side, option number C. Are your point is clear? Right? Let us see one more question. Okay, one more question over here. We are coming to the end of it. But a 69-year-old man, an old man is diagnosed with a dysarthria. You should know what is dysarthria. It is not a orthopedic problem. Arthro does not every time means joints only. Dysarthria, disarticulation of speech. So old man is diagnosed with the dysarthria. The history reveals that the man has had this problem for several weeks. Okay. MRI shows an infarcted area in the brain stem on the right side. Problem is in the brain stem on the right side. Fine. What is the problem? Dysarthria. Damage to which of the following structures would most likely explain this deficit in this man? Patient is not able to articulate the speech for a couple of weeks. You ordered an MRI of the brain. You're seeing a lesion on the brain stem on the right side. Fine. Which nucleus? Answer. Which nucleus? Is it a cuneate nucleus? Is it a nucleus ambiguous? We are actually merging head, neck and neuro over here. Is it a solitary tract nuclei or a spinal trigeminal tract? What do you think, guys? What should be the answer? Think. B's are coming. What is B over here? Very, very good. Nucleus ambiguous. 9th, 10th, 11th nerve, combined nucleus, motor nucleus. And if I may ask you, write in the comment box, falls under which functional component? Which somatic efferent, visceral efferent, visceral afferent, whatever those names were, you have to answer this. But nucleus ambiguous is made up of these three nerves, and they are motor to the palates, the pharynx and the larynx. Now obviously these muscles are not working fine. There will be disarticulation because palate, pharynx, larynx, they are involved in voice production. And we say larynx is the voice box, but it's only a small part of it. The air only goes out through the vocal cord, then it comes into the oral cavity, the pharynx and the palate, and then the sound comes out. Through the nose also, paranasal sinuses also. So voice box does not mean that there is an on-off button over here. It is a combined activity of the whole facial skeleton. So yes, so I was asking you which functional component? Anyone? Still waiting for your responses. So see, it is a motor, so efferent. Motor efferent. Which efferent? Somatic or visceral efferent? Visceral efferent. General or spatial? Spatial visceral efferent. Why? Because it is from the pharyngeal arches. Branchiomotor. We also call this as the branchial arches, or we call this whole as a branchiomotor. Remember pharyngeal arches. So what about pharyngeal arches? Pharyngeal arch had first arch, second arch, third arch, fourth and sixth arch. Fifth arch is missing, I hope you all know. First arch, what is the nerve? V3. Second arch nerve is 7th, third arch nerve is 9th, fourth and sixth arch nerves are basically branches of 10th. Superior and recurrent laryngeal nerve. Superior laryngeal nerve and recurrent laryngeal nerve, right? Pharyngeal arches, fine. This three combined, that is 9, 10, because 11 also runs with it, what we call as a nucleus ambiguous. This whole is spatial visceral efferent. We have done a session only on the cranial nerve functional components. If you are weak in this particular topic, I would advise you to go through it. You can have a look at them in the spatial classes as well as in the YouTube sessions. So don't worry much about it, right? So this is the nucleus ambiguous, spatial visceral efferent. That was the answer. Fine. I hope. Do we have one more question? Okay, one more. This is probably the last one, I guess. Yes, this is the last one. All the best for the last question, guys. 55-year-old male farmer is admitted to the emergency after falling. Okay. Radio examination reveals a small depressed fracture of the skull. vertex and thrombosis of the superior sagittal sinus. Okay, so they are saying that there is a superior sagittal sinus thrombosis. A day later, the patient loses consciousness. Okay, just see, imagine the patient over there. He just fell down and he had a skull fracture. Slowly, he had loss of consciousness, unconsciousness. What is the most likely cause of this unconsciousness? Answer over here is not, I don't think, very tough question, but yeah, still. There is a obstruction of CSF resorption. There is obstruction of the cerebral aqueduct. There is laceration of the middle meningeal artery. There is fracture of the cribriform plate with the CSF rhinorrhea. Think anatomically, what is the function of superior sagittal sinus, because it is getting blocked. Thrombosis of the superior sagittal sinus. Rahul is the first one to answer. Answer over here, yes, very good. I guess we discussed it slightly yesterday also. Arachnoid villi, remember arachnoid villi. So all of the CSF gets absorbed into the superior sagittal sinus via arachnoid villi. And if the superior sagittal sinus itself is getting blocked, obviously the CSF will not be able to absorb, but the formation is occurring inside the ventricles. Okay, so inside your brain the fluid is being formed, but it is not getting absorbed. What will happen? Obviously, what will happen is that if you look over here, that suppose this is the brain, inside this was the amount of fluid normal, just hypothetically, and it gets absorbed over here. That is a normal thing. Now what is happening? This is now blocked, but inside the fluid is being secreted slowly. So this will expand or not? Yes or no? It is going to push. It is going to push the brain inside the skull, and the skull is fixed outside. So there is a loss of consciousness. Simple as that. Answer is our obstruction to CSF resorption. Other options are obstruction to aqueduct. It is nothing. It is in the midbrain. Middle meningeal artery is present on the sides. Pterion, remember P silent, pterion over here. Extradural hematoma. Fracture of the cribriform plate. I guess we already know that is in the center. CSF rhinorrhea. Once the patient bends down, the water droplets come out of the nasal cavity. CSF rhinorrhea also could be a pre-feature or a feature which is before developing meningitis. Fine, so this was answer is option number A. So that's all guys. I hope you enjoyed the session, and these were our MCQs, and we'll meet again tomorrow with some other topic and with those high yield MCQs. Fine, thank you for your time. Any problem you can write in the comment box, also in the Telegram groups. That's all. Good night and take care.